AIHM Wellness webinar. We're super excited today on this AIHM Weekly Wellness webinar to have Amanda Harris and Heidi Miller here with us. And today we'll be talking about addressing chronic pain and integrating physical function services into community health centers, along with the Academic Collaborative of Integrative Health. Next slide. So as we're letting people join into the webinar, I just want to take a minute and welcome all of you back who are here in the AIHM and ACIH community. And also for those of you who are new, we are a global interprofessional integrative health association working to transform healthcare, body, mind, spirit, community, and planet. And the Academy in early 2021 merged with the Academic Collaborative for Integrative Health. And we're super excited to have them presenting today on this very important topic. So for those of you who this is your first time with us, if you have to leave for any reason early, or if you want to share this webinar with colleagues after, you can always go to our YouTube channel, youtube.com/AIHM Global, and all of our presentations are available free to the public and can be found there usually within a day after the live event happens. So just a little bit about the Academic Collaborative for Integrative Health. The ACIH core members are national academic organizations and individual colleges associated with the 5 licensed integrative health and medicine professions. So in the United States, that's acupuncture and East Asian medicine, chiropractic medicine, naturopathic medicine, massage therapy, and direct entry midwifery. ACIH membership also includes organizations representing traditional world medicines and emerging U.S. professions that are engaged in self-regulation and or working towards future licensure here in the United States. So before we get started with the webinar, I just want to invite any of you who are thinking about studying more deeply. We do offer an integrative health and medicine fellowship. And if this is your first time learning about that fellowship and you decide to join, you can use a discount code from this webinar and just mention that you came to the ACIH webinar and you'll be able to get a $1,500 tuition discount. So I'm going to turn it over to my esteemed colleague, Mitchell Zeifman, and let him take it away. Thanks.
Thanks so much, Tabby. My name, as Tabby just said, is Mitchell Zeifman. I'm a naturopathic doctor, and I've been working with the Collaborative for a number of years on their clinical education working group, and I'm the project lead for this integrative practice webinar series. So I'd like to welcome everybody to today's integrative practice webinar, addressing chronic pain and integrating physical function services into community health centers. Just a little background, this is the 12th webinar in our series since 2016. This series has endeavored to spotlight integrative clinics that have demonstrated innovation, leadership, and service in the field of integrative care. And our mission is to provide successful examples of integrative care clinics that are effective, sustainable, and improve patient care for the edification of clinicians, educators, and students. Today's presentation is highlighting the St. Louis Regional Health Commission's Chronic Pain Initiative, and the talk's going to focus on the 3 major work streams in the initiative: policy, reform, public health communications, and clinical improvement. The majority of the presentation will review lessons learned from integrating physical function services into St. Louis-based community health centers, and I'd like to introduce our 2 presenters now. First is Dr. Heidi Miller. She's the medical director for Gateway to Better Health at the St. Louis Regional Health Commission. She also serves as a primary care doctor at family care health centers and consults on health quality and equity issues for the St. Louis Integrated Health Network, Siteman Cancer Center's Breast Cancer Partnership, and the Missouri Primary Care Association. Welcome, Dr. Miller. And Amanda Harris is the Director of Regional Initiatives at the St. Louis Regional Health Commission, where she leads the organization's Chronic Pain Initiative. Prior to serving in this role, Amanda received a Fulbright Scholarship to conduct research on an intercultural birthing initiative in Chile. She graduated from Washington University in St. Louis in 2016. Ms. Harris and Dr. Miller are champions for patient-centered integrated care. Their foresight, motivation, compassion for patient care accelerated the adoption of various non-pharmacologic pain management and functional restoration therapies within the primary medical home for underserved patients. The work they will be describing today will have a lasting impact on reducing health disparities locally and should serve as a model for adoption nationally. So welcome, Amanda and Heidi. Thank you.
Thank you so much for the nice introduction and the honor of presenting with you. We realize that the participants on this webinar represent a robust international and multidisciplinary group, and we love this. That's what this program was all about. So we are among kindred spirits. So the title of our talk is Addressing Chronic Pain, which is an epidemic in the United States and beyond, and integrating physical function services into community health center. So these physical function services, as my partner, Ms. Harris, will explain, include physical therapists, chiropractors, acupuncturists, occupational therapists. And in the United States, our community health center network is a nonprofit, partially sponsored government approach to taking care of the safety network and the many hundreds of thousands of patients we have in the United States who don't have health insurance. So here is our outline for today. First, we'll just explain who we are, and that'll help put this into context. We'll explain what the St. Louis Regional Health Commission is. Then we will proceed to describe this chronic pain initiative. And then a special note that we realize we can't do anything for chronic pain, for a safety network community, a vulnerable community, without it being trauma informed. And in fact, our stakeholders told us, don't you dare spend any time or waste any resources on chronic pain management unless it's trauma informed. Now, we save time at the end for questions and answers. However, Amanda and I would like this to be interactive. If you have questions during the presentation, we welcome them. And if the question is really long, we might turf it to the end of the presentation. And at the very last slide, you have our email addresses. So if we run out of time for the really good, robust questions, we can correspond via email, as we consider you our colleagues in working together, trying to help our patients suffering in chronic pain. So go ahead and throw your questions in the chat if you have questions as we go along. First section, who are we? Well, in St. Louis County, 1 out of 10 people, and in St. Louis City, 2 out of 10 people are living at or below the federal poverty level. Health disparities in the St. Louis region are predicted by zip code. Our North City, North County, South City, we have the highest rates of the uninsured and the lowest health outcomes. This is a patient of mine. Can you read her t-shirt? It says, "We must start loving each other. Now is the time." And it is superimposed on the Gateway Arch, which is a symbol of our city. I took this photo soon after the tragic killing of Michael Brown in Ferguson, Missouri. And when I asked her permission to share this photo, she agreed. And then she said, "Oh my gosh, I'm going to be famous." So in taking care of our patients and evaluating the health outcome by zip code in our region, we have realized rapidly that we just needed to move beyond measuring atrocious healthcare disparities and plow forward into action, into promoting equity in real ways. And we want to provide access in a manner that promotes health outcomes that is not a direct function of race, zip code, or income level. So toward that effort, the Regional Health Commission was formed 20 years ago. In 2001, we had a collaboration of St. Louis City, St. Louis County, the state of Missouri, health providers, community members, to improve the health of our uninsured and underinsured citizens of St. Louis City and County. And the mission statement of our organization is to increase access to healthcare, to reduce health disparities, and improve health outcomes in our region. So one of our biggest programs, or one of the main programs of the Regional Health Commission, is Gateway to Better Health. This is a coverage model that the Regional Health Commission came up with as a means to cover thousands of patients who didn't have health insurance in our region. And this model, with the help of a federal grant, covers adults between the ages of 19 and 64. So where we're at as kids, it's a little easier to get health insurance, and as seniors, it's a little bit easier to get health insurance, but in between there has been a massive gap. So Gateway to Better Health was a coverage model to take care of those patients. It was initiated in 2012, and it was intended as a bridge to the Medicaid expansion that was a part of the Affordable Care Act under Obama. Now, it is 10 years later after that act was passed, and just now, as of a month ago, Missouri did implement Medicaid expansion. But this Gateway to Better Health project was meant to be a bridge, like a year or so. And as our legislators did not approve Medicaid expansion to cover patients in Missouri who were under the federal poverty level, we continued this very long 10-year bridge. And it is ongoing as we try to transition to Medicaid expansion. So just to give you a snapshot, like annually, and these numbers are from 2018, we covered nearly 22,000 patients. 62% of those were of the uninsured. 28,000 primary care and dental visits, nearly 6,000 specialty care visits. And we're going to return to this because this is where our chronic pain initiatives stem from. And then we paid for over 176,000 medications to manage chronic conditions and other diseases. In our region, we have 5 community health centers. And these health centers in our region accept patients regardless of their ability to pay on a sliding scale, or they have served as a primary care portal to this Gateway to Better Health program. It's not something that you just sign up on your own. You can sign up through our health centers to immediately engage in a primary care home. The health centers specifically foster interdisciplinary care with behavioral health, with substance use, and with now physical function experts in order to improve health outcomes. So over the years, Gateway to Better Health has meticulously tracked and honored every single referral request for their patients from the primary care providers for specialty care. These columns here represent different specialty services provided. So can you guess which specialty was requested the most? What does this blue column represent? Ortho. It was orthopedics. 15% of all specialty care referrals in our safety network, month after month, year after year, was for orthopedics. It surprised me. It was more than GI. It was more than cardiology. It was more than surgery. So why? Why so much ortho? We needed to understand our patient population, and we also needed to be stewards of our limited funding. And so that led us to the evolution of this chronic pain initiative. We want to share a timeline of our origin story with you. And it was in 2016 when we decided to take a deep dive into figuring out of all these patients, multifaceted needs. Our patients have multiple chronic diseases. Why was ortho the most requested specialty? So the Regional Health Commission launched what we call the Orthopedic Referral Study. We analyzed our referral data for all musculoskeletal related specialties, and then we interviewed 3 specific categories of stakeholders. We listened to patients directly. We did a focus group of primary care doctors that were in the safety network trying to take care of patients. We did individual interviews with our orthopedic specialists. And here's what we learned. Patients reported that they were in so much pain. They reported that they felt bounced from one provider to another without any resolution of their pain. And they described patient-doctor interactions with the specialists that were particularly trauma uninformed and at other times overtly racist. Now, when we talked to the primary care providers, they were struggling. 15, 20-minute appointments to manage congestive heart failure, diabetes, hypothyroidism, and severe knee pain in a patient who's 400 pounds. They needed help. Now, when we talked to the orthopedic surgeons, they complained. They complained that the primary care providers were sending them, quote, inappropriate referrals because many of their patients were not eligible for surgery. Now, orthopedic surgeons are surgeons. They like to operate. And in the process of interviewing them and exploring this dynamic of this high demand for orthopedic care, we learned an unfortunate and derogatory term used by surgeons called a hit rate, short for surgical hit rate, that reflected the percentage of your ortho clinic of those patients that would actually go to the operating room. And if that rate was too little, then they were upset that the primary care providers were sending them so many patients that were not surgical candidates. So clearly we saw a mismatch and a use of resources that was not optimal, sometimes wasted, and even a very derogatory and diminishing way to take care of patients. So in summary, this orthopedic referral study showed that we have a lot of chronic pain and they don't all go to the operating room, and we needed to figure out how to do this better and how to do it in a trauma-informed way. And so, Amanda, I turn it over to you.
Thank you, Heidi. Well, perfect segue. And so in 2018, we launched what we call the Chronic Pain Initiative. Next slide, please. And before I go into what consists of the initiative and what we were able to accomplish collectively, I want to helicopter up for a moment and dive into some more data. So from that orthopedic study, we, as Heidi said, learned about the problem, and we wanted to dive deeper into multiple perspectives. And so when we surveyed our own gateway patient population using the definition of chronic pain as maladaptive, prolonged pain exceeding 3 months, we found that over half of our patients said they had chronic pain. And we know that this is over twice the national prevalence, which is 1 in 5, according to the CDC. And when we understand the literature, we know that chronic pain is not spread out evenly over the population. Folks with low income, those who speak English as a second language, older adults, women, other populations suffer from chronic pain at much higher rates. And so this became a real priority to understand the burden of chronic pain and to take immediate action. Next slide. And we also surveyed our primary care providers. Oh, before I go there, one more interesting thing about from our patients. We've heard, of course, that chronic pain is both a physical and emotional and mental disease, and our patients are very aware of that. When we surveyed them, many said that their pain made their anxiety or depression get worse, and almost half said that their anxiety or depression made their pain get worse. And so they understood this interconnected nature of physical and emotional pain and how that played into their chronic pain. Next slide. And our providers also shared that they felt like they didn't have enough training to properly treat chronic pain. We heard that 2 in 3 of our providers, and this includes both physicians, nurse practitioners, and other nurses, said that they did not have enough training to adequately treat their patients for chronic pain. And 3/4 of our providers said they didn't have enough time. So we knew any solution that we led had to take this into account and not only provide more training, but also provide more resources within the primary care health centers to treat chronic pain. Next slide. And finally, from a systems perspective, we understand that the chronic pain crisis is very intertwined with our opioid epidemic. And when we heard from our providers, they said more than half said that they would prescribe less opioids if they had other places to refer their patients or if they had other tools in their toolbox. And so this was very captivating, especially in St. Louis, where we're seeing high rates of opioid use. And we knew that by addressing chronic pain, an uproot cause of opioid use, that we could make substantial strides in both simultaneous epidemics. Next slide. And so now we get to our chronic pain initiative. And so from all of this data, we synthesized 2 goals. 1, prevent chronic pain from happening in the first place. And 2, let's improve the treatment of chronic pain within our system. And so we wanted to approach these goals using multiple tools as we do in integrated care. And so we looked at policy, clinical improvement action, and public health communications to accomplish this. And I'll dive into each of these 3 buckets of work. Next slide, please. So to start, we wanted to ground ourselves in what are the national strategies, what is the literature, what is the evidence around chronic pain management. And so we interviewed over 50 individuals in our region, and we read 200 articles plus on chronic pain management. And we heard from diverse perspectives, from chiropractors, from physiatrists, from psychologists, from people who have chronic pain themselves. We really wanted a full picture of the crisis. Next slide. And what we found were 3 major themes that emerged. We found that chronic pain has to be treated as its separate but intertwined epidemic. So we can't only focus on opioids, we have to understand the full complexity of the chronic pain epidemic. We must use a trauma-informed approach to manage chronic pain. And Dr. Miller will go much more into this bullet later on in the presentation. And then finally, we have to treat chronic pain as a chronic disease. So as we do diabetes, using multiple professions and disciplines that are integrated to provide optimal care, we need to mirror those efforts to treat chronic pain. Next slide, please. And so we crafted a policy document, which is on our website that I'll drop into the chat momentarily. And this paper outlined our goals at a federal, a state, local, and institutional level. And over the past few years, we've been able to accomplish a lot of great policy work collectively as a state. Last year in legislative session, we passed our legislation that allowed us to have a PDMP, a prescription drug monitoring program, which will hopefully help link individuals who have substance use disorder to treatment and make sure they have the resources they need to treat their chronic pain outside of opioids, which we know are not evidence-based for chronic pain. And then a couple more policies I want to highlight. We expanded our coverage for physical therapy and for chiropractic within our Medicaid population, which we're very excited about. And we were able to, through the Regional Health Commission's Gateway to Better Health program, add additional services, which I'll go much more into detail about later. So with all of these system-wide policy accomplishments, we were able to really move the needle on what resources are available specifically for safety net patients. Next slide, please. And so that moves us into our next bucket of work, our clinical improvement. And so we knew that we had to think back to the data that we collected from our orthopedic study and understand how can we improve and bolster services at the primary care level to prevent unnecessary referrals. How do we better streamline referrals that are needed for specialty care and preserve access at the specialty care level? And then finally, how can we educate providers across the board on the importance of interdisciplinary care, on trauma-informed care, and best practices for patient activation? Next slide, please. And so we launched the chronic pain initiative, hoping that we could integrate new services into our community health centers, and they really took the torch and ran with it. It's amazing the resources we have now within our community health centers compared to a couple of years ago, and it's really from their leadership that this is possible. And so a couple of years ago, we started the process of applying to CMS to integrate and cover new physical function services as part of our Gateway to Better Health program. And so our goal is to integrate physical therapy, occupational therapy, chiropractic services, and acupuncture within our community health centers. We know that it is difficult often to refer out, and we know that the retail model for many of these disciplines can be cost restrictive for patients with limited coverage options. And so we wanted to think innovatively about how can we best partner and integrate these services and really have amazing resources at the tips of people's fingers who need the resources most. Next slide, please. And so when we use the term physical function expert, we're including multiple disciplines because we found from all of our stakeholder interviews that while each practitioner had their own specialty, there was a lot of overlap in their goals. Their goals were to increase function, promote movement, and promote patient activation using active modalities. And so we use this language to have an inclusive definition to refer to multiple disciplines. Next slide, please. And I'm going to turn it back over to Dr. Miller to go over some of what we learned from integrating these different professions into our community health centers.
Thank you so much. And a special note to our international participants. In the United States, we like to do things as expensively and inefficiently as possible in our medical system. It's very doctor-centered and hospital-centered. And unlike Canada, for example, you cannot see a physical therapist or a physio unless you have seen the doctor first, and the doctor determined that you needed that, and the doctor gives an order for that. So there's a lot of barriers to care. It's been this uphill battle in trying to change policy so that we can be more pragmatic, more patient-centered, give patients the services that they need most, and to also recognize that our multidisciplinary experts actually handle chronic pain much better than people like myself with a medical degree do. And we have a great need to collaborate. So our stakeholders and multidisciplinary experts from a rapid improvement event that we did provided many tips regarding trying to integrate these physical function experts within primary care. So in our medical system, primary care is sort of the entry point. So instead of sending people out as a second step to go do something else for healing, we were trying to bring everyone under one roof so that we could work collaboratively. And that's where this physical function expert took place. And as we were planning this, we got fierce advice. And this is it in 8 points. Number 1, emphasize active modalities. Okay, we got limited funding, we got limited time, we got limited exam room space. Let's do interventions that are evidence-based, but active patient-directed, like therapeutic exercise. Secondly, our stakeholders recommended prioritizing referrals for the following conditions, because we can't do everything for everyone. Let's focus on acute pain at high risk of turning chronic. Now we know for sure, and we'll present this later in the presentation, anyone with a history of trauma has a statistically increased risk of their acute pain turning into chronic pain. That's where you intervene. Acute pain is quite treatable. Chronic pain is extremely difficult to treat. We also wanted to focus on chronic pain, which had a high functional impairment, pain with co-occurring disorders like mental illness, and also patients who had pain with an unclear diagnosis. When the primary care provider is just about to order imaging or radiology tests, this is where our physical function experts can really do a better job to reevaluate and say, hey, hang on, let's try to do something before just radiating with them. Number 3, we were told to ensure both pre and post visit communication with the care team and warm handoffs. So basically, if a primary care doctor and a chiropractor are working under the same roof for the same patient, ideally, let's say I'm seeing a patient as a primary care doctor for their diabetes, and the A1C is way too high, the sugars are way too high, and their back pain is killing them. And how are they supposed to take their insulin and eat healthy when they are in agony? They're suffering every single day. If I can do a warm handoff, literally ask the chiropractor to come in the room, meet the patient, introduce I can introduce the patient and the chiropractor brings the patient into their room. That's a warm handoff, and that was a very strong recommendation, and we've had success with that with behavioral health integration. So why not extend that best practice to having our physical function experts operating with the primary care provider and doing these warm handoffs with clear communication. We were also told to set clear expectations regarding functional goals for patients and providers. So we need to move past, and certainly us medical doctors, the MDs and the DOs, we need to move past this very wicked 1 to 10 pain scale. That works great if you just had your appendix out and in the first 18 hours of pain management, tell your nurse what level your pain is. It doesn't work beyond that. And in fact, that's how we ended up with a catastrophic opioid epidemic. Number 5, encourage integrated multidisciplinary treatment. This is evidence-based care. So having a primary care, our physical function expert, pain specialist, and in particular, we have behavioral health staff that is already integrated in our primary care model. They're incredibly important for our chronic pain management, especially if a patient has fear of movement. And as Amanda had said earlier, pain is depressing, and depression makes pain worse. So trying to manage chronic pain without a behavioral health consultant, either a social worker or a psychologist, is short-sighted. So collaborating with them, as well as our new colleagues in the United States, our community health workers are really saving us in terms of helping our patients with social determinants of health, as well as many other team members, including our front desk staff, who know when to get a patient in right away because Ms. So-and-so is having a flare of her pain. Number 6, recognize and leverage the triage and diagnostic skills of the physical function experts. Okay, you might find this obvious, you might find this insulting, but frankly, MDs and ODs don't know what any other provider does and what their skill set is. So just as an example, most of the physical therapists in our region have a doctorate in physical therapy, and they are skilled at making diagnosis, not just treatment. And most of our local doctors don't know that. So, okay, let's just keep integrating and talking to each other and respecting the skill set and the expertise of our colleagues. All right, number 7, promote patient education, patient activation, patient self-actualizing, and patient empowerment. Number 8, promote provider and staff education. As I just implied, like, we need teaching. The medical folks were really good at prescribing things, but as we integrated physical function experts into our health centers, we have asked them, we have charged them to teach us. Go ahead, give us a 30-minute presentation on back pain at our next provider meeting. Let's keep learning from each other. Okay, Amanda?
Thank you. And so, as Heidi mentioned, we had to rethink when we implemented this benefit, how are we going to measure it? We knew the 1 to 10 pain scale was outdated and didn't work. And so what could we use to measure functional improvement? And so we landed on a patient-specific functional scale. And this is how we measure the efforts of our benefit, where it's very patient-centered. They choose their activities that they want to work on, and they rate how their pain is interfering with their goals. And so we still need to analyze all of this data, but we're excited to use this lens to think through the benefits success. Next slide, please. And I'm really excited to share this resource. This was drafted by Javeen Khan, who is a resident at Logan University, and she's a chiropractor. And she has synthesized so much of our learnings through implementing this physical function benefit and all of the pre-work that we did beforehand, interviewing different practitioners, and has written it all and captured it in this document. And it's free and it's available on beyondpainstl.com. So if there's a part of this integration model that you want to learn more about, or if there's budgeting information or logistics, it should be captured here. So we're excited to share this with you today. Next slide, please. And I'm not going to go into the nitty-gritty of this diagram, but I just wanted to highlight that in addition to bolstering the services within primary care, we also wanted to think about how do we optimize our referral pathways? And so the big takeaway I want you to have from this slide is that there's two arrows. We needed to improve the way primary care providers and other practitioners were able to refer to specialty care like ortho, and we needed more bidirectional learning so the specialty care providers can inform the providers and the care teams on how to better their referrals and how to better treat chronic pain within the primary care health home. And so we launched in collaboration with WashU, which is a hospital system in St. Louis, this model, this triage model, and we're seeing less duplicative referrals. We're seeing more expedited care and patients getting to the correct referral destination. And we're seeing, I think, more clarity from the primary care health home. And so we're excited to keep analyzing the data because it's all preliminary and qualitative right now. But we're hopeful that this model of bidirectional communication will really help with our referral process and get at what we started with of having a lot of orthopedic referrals and instead see other more innovative, integrated ways of caring for our patients. Next slide, please. And so lastly, we know chronic pain is not managed just within clinics' walls. And so we were very intentional about launching a simultaneous communication plan to reach folks in their homes, to reach community members suffering from chronic pain, and to help educate caretakers and other advocates. Next slide. And so we launched Beyond Pain STL, and this website has a slew of resources that are geared towards providers, for people with chronic pain, and for community advocates. And we have patient-centered videos in plain language. We have handouts, we have workbooks. So I'd love anyone interested to explore and click around because I think you'll find some helpful tools. Next slide. And on this website, we also have a lot of social media language available to share. So if you're looking to help get the word out and help educate your clients or patients on chronic pain, it should be very accessible on our website to download graphics and videos and language and share it out. Next slide. And then lastly, we have a chronic pain workbook on Beyond Pain STL. And this workbook really helps individuals understand their chronic pain, help them recognize patterns and see how changing their routine or focusing on different components of their life with mindfulness and other tools can really help improve their chronic pain and functionality. And so this resource is, again, free and it's on our website, and it's been really helpful for patients who have used the workbook regularly. And with that, I will turn it back over to Heidi.
Okay, so this brings us to our final part of our talk, talking about trauma-informed pain management. We knew that we couldn't do anything for our patients in terms of chronic pain without us implementing trauma-informed care. As Amanda had mentioned earlier, this policy paper, one of the main tenets of it was to use a trauma-informed approach to manage chronic pain. So let's get some context here. This is a journal entry shared with me by one of my patients who granted me permission to share with you. It reads, "Deep inside, I want to run and hide from all this pain, which could drive any man insane. Yet I cry, I feel, yet I cry, I feel, I live to fight one more day sober." This is a patient of mine who has had trauma, chronic pain, and substance use disorder. It's really important for us not to dissect our patients into different problems and different parts. I know that you realize that, but we need to keep, and Amanda and I have worked really hard to educate our medical peers. Because we know that each of these parts kind of feed into each other, and we need to take care of the whole patient. And trauma-informed care enables us to do so. We can't understand chronic pain without understanding trauma. We know a history of trauma statistically escalates the risk that acute pain is going to turn into chronic pain. And we know that pain and trauma are just wickedly intertwined. So to begin the conversation about trauma-informed pain management, we should review the 3 distinct elements of trauma. And you've already seen these likely. These are the 3 A's of trauma: event, experience, and effects. So let's just focus on the event. This places the cause of trauma in the environment, not on some individual patient defect. Examples of events featured in the ACEs study can include neglect, rejection, abuse, among others. An event can be emotional, social, or physical, but it's key not to overemphasize one event. As more commonly, and we've seen this in our population, trauma can be the accumulation of many events over a lifetime. And in the case of racial inequities, over multiple generations. So this is exactly why we ask our patients no longer what's wrong with you, but rather what happened to you. Now let's talk about the experience. Focusing on experience highlights the fact that not every child or adult will experience the same events in the same way. A particular event might be traumatic for one person and not the other. And there are studies that show that siblings in the same house subject to the same event may experience it differently. Unique individuals with unique resilience factors will respond in unique ways. So recognizing and respecting that enables us to best understand and care for our patients, clients, peers, and loved ones. And we need to remember that only the person who experienced the event can say whether it was traumatic and what was traumatic about it. Now, finally, the effect. We understand there's a broad range of potential effects of trauma on our health, on our relationships, our behaviors, on our longevity, and on our level of suffering. This is where chronic pain comes in. Adverse effects may occur immediately, or they may have a delayed onset. And in some situations, the individual doesn't even recognize the connection between the traumatic event and its effects. Our response to these effects need to be holistic in approach. And treating all effects as just physical symptoms or behaviors that need to be corrected without insight to their traumatic etiology is short-sighted and ineffective. And this is exactly how our United States medical system screwed up pain management and contributed to the opioid epidemic. So patients in pain most expertly understand this convergence of physical and emotional suffering. And a growing body of research reaffirms this dual processing of chronic pain. Neurologic mapping shows that the same region in the brain associated with processing emotion is activated by chronic pain. The Regional Health Commission, in partnership with a local nonprofit organization called Alive and Well Communities, which supports trauma-informed care, both in healthcare and education. Together, we developed this framework to expound on this relationship. So here's the complete diagram. And well, I know it seems complicated. We're going to break it into parts and we'll go through quickly, but this model does not capture the entire complexity of chronic pain, but the objectives of this model is to demonstrate how trauma, both emotional and physical, can lead to the onset and progression of pain. It also reveals the connection between emotional chronic pain and physical chronic pain through a shared neurologic response. And it shows that interventions to address trauma and prevent the progression of emotional and physical pain are very similar. So think of this progression as our current status quo, not the goal. This is where we need to intervene. So we'll walk through the model section by section, but first I want to focus on trauma. This study in 2018 by Mainz discusses evidence suggesting the association between psychological and physical trauma and chronic pain. And this is quoted: "There are strong prospective links between early life traumatic experiences and the subsequent development of chronic pain. And the presence of past trauma," and this is a statistic worth remembering, "has a 2 to 3-fold increase in the development of chronic widespread pain." You know, I took care of patients for a long time before I was able to learn about trauma-informed care about 5 to 10 years ago. But now I understand the role that trauma has, enabling us to understand, and now we understand the role of trauma in how someone experiences an injury. So now I understand where if you have, imagine two patients who had the identical motor vehicle accident, they were both a restrained driver, the accident occurred on the same day, and they incurred the exact same injury. Now I understand why one person might bounce back after 2 weeks, and the other one walks into my exam room 2 years later, still using the same cane, limping since their motor vehicle accident 2 years ago. We understand that trauma plays a role there. So now we'll look deeper into this shared neurologic response from chronic physical pain and chronic emotional pain. And this study is really interesting. So chronic pain diagnoses have been well documented associated abnormalities in brain structure and function. So we knew by functional MRI imaging, reviewing over 4,000 patients, that when someone is having pain, their brain may light up in this region. This study queried if there was a difference in brain activity related to the sensation of chronic pain versus acute pain. And if there is, then how does the brain reorganize itself in the evolution from acute to chronic pain? So they recorded brain activity for subjects with back pain. They compared subjects with new back pain of about 2 months duration, which they labeled as acute. They compared that to patients who had back pain of over 10 years and labeled that as chronic. In the subset of patients with acute pain, they followed them longitudinally for over a year, and they compared brain activity between patients who recovered completely and those patients who did have persistent symptoms resulting in chronic pain. The results demonstrated in meta-analytic probabilistic maps related to the terms pain, emotion, and reward. And I included the mapping for pain and emotion here. So here were the findings. Brain activity for acute back pain was limited to regions well documented to be involved in acute pain processing. But for the chronic back pain patients, their brain activity was limited to the emotion and limbic circuitry. And then the patients who initially had acute back pain, if their back pain resolved, the brain activity of pain, that registered pain resolved. But if they progressed to chronic pain, their brain activity actually shifted and it increased in the emotion-related circuitry. So in summary, this very interesting study did 3 things, 3 key findings. Number 1, the brain processes acute pain and chronic pain in different parts of the brain, even though it's the same part of the body. Number 2, the location of chronic back pain overlaps with the emotional limbic circuitry. And third, if a patient's acute pain resolves, the brain activity reflecting that pain processes diminishes. But if the acute pain persists into chronic pain, the distribution of brain processing of that same back pain dynamically shifts to the emotional limbic system. So this study provided new insights about the mechanism and definition of chronic pain. And we've used this study to educate our peers that in fact, chronic pain is different than acute pain. They're like 2 different conditions. So let's speak to interventions. They play a key role in stopping this chronification of pain. How do we deter this progression? How do we infuse resilience in our patients and foster systems to support them? Well, we know that to help individuals cope with physical, emotional, and mental aspects of chronic pain, they have to occur both within the clinic and within the community. And Amanda spoke to that work in the community. Within the clinic, in addition to providing multidisciplinary integrated clinical services, we also need to encourage providers to be trauma-informed. In other words, to recognize and respond to how emotional stress and traumatic events impact patients' experiences with pain. And we have to educate, and we have worked very hard on this. We need to educate primary care providers, physical function experts, behavioral health consultants, and even our orthopedic surgeons on the intersection of physical and emotional pain and how to apply the principles of trauma-informed care. So here are the principles of trauma-informed care. And we have used these specifically through the lens of chronic pain. Most important thing is that we empower the patient. We don't disempower them. We don't show them an MRI of their spine that shows one disc that's abnormal and make them feel like that's a sentence and a punishment for the rest of their life. We focus instead on what we can do to empower them as we're improving their function. They need to feel safe with us in order for them to tell us the truth about how they're feeling and how they're responding to the way that they are feeling. This fear of movement is one of the biggest barriers for chronic pain. And so the safety and knowing that it's safe to move is key part of trauma-informed care. Collaboration, well, we and our patient and all of our multidisciplinary specialists, we are all on the same level. We are democratized. We need to interact together. We all have expertise. Then it's also very important for the patient to have choice in treatment. We need them to trust us. And then there must be equity in the provision and the opportunity to seek chronic pain management. Now, I'll stop there. We have a whole second talk on trauma-informed care, but I wanted to touch on it briefly as this was very important in not just incorporating physical function experts into our integrated model, but we all need to be operating under the same moral imperative to provide trauma-informed care. Okay, this is our last slide, and we'll have additional time for questions. Couple of final tips in going through this process over the last couple of years in trying to integrate chronic pain management that is trauma informed. Number one, we had to recognize and promulgate chronic pain as a preventable chronic disease. So in our community health centers, we actually do a really good job of diabetes management. And if you think about it, like, what is the best diabetes management? Is it proactive? You check in, it's multidisciplinary. Let's apply those same principles to chronic pain. Let's piggyback on something that we're already good at and then expand beyond that. Number two, as Amanda mentioned, we needed to focus on this triad of policy, clinical interventions, and communication strategies. We needed all three of these to make any difference in our region. Number three, solicit and uplift the needs of our patients. We interviewed them directly, we surveyed them directly, and then we threw these survey results in the face of our providers, our legislators, our specialists. We need to prioritize community voice, and our organization, the Regional Health Commission, we have a number of advisory boards, one of which is our Community Advisory Board, who were the ones to approve this initiative in the first place and tell us, don't you dare do anything with this unless it's trauma-informed. Number five, engage diverse multidisciplinary informants. And we did this through our rapid improvement event. Number six, respect and leverage current programming in place. So as we tried to introduce physical functions into health centers, there were a few health centers that had a head start on having chiropractic on site. And so we realized in order to have organizational change, we have to deeply listen and deeply respect to what they are already interested in doing, how they want to implement that and work within that. And then number seven, we needed to honor and replicate best practices. So as I mentioned, our community health centers have worked extremely hard on behavioral health integration, and to do that with warm handoffs at the same location. And so we use that model to incorporate the physical function experts. Number eight, we want to align our efforts with current pressing needs. So pairing the chronic pain management with all of the efforts to thwart the opioid use epidemic. Number nine, we got a special audience with teaching doctors. Yeah, we've had to do the most education of doctors, not of patients, doctors. But it's been well received. Number 10, we have to be very intentional with integration and our interface between disciplines. Whether we're referring on site or if we're referring off site, it really takes tending to, like a garden. Like, we need to be intentional. We can't just throw out a referral and assume that the patient gets seamlessly from point A to point B. And then number 11, we need to onboard all staff with trauma-informed care. So we trained all of our staff, but every time we have a new person join us in our health centers, we need to educate them on trauma-informed care. I will stop right then. And these are our emails if you would like to contact us in the future. And this is the website for our the Regional Health Commission, and Amanda also added the link in the chat to the part of our website that's devoted to chronic pain. Okay, we'll stop there. Any questions? And
Thanks so much, Heidi and Amanda. If there are questions, they can be put into the Q&A section and we can read them. Raise a hand. I want to say that that was an amazing presentation. Thank you so much. It was so comprehensive and compassionate in its in the approach that you deliver and that you're showing. I was really felt it was incredibly wonderful. Tabby, you have a question or a comment?
Yeah, so I do have a question. I can't put questions in the Q&A, unfortunately. But first of all, thank you so much for this presentation. It was so phenomenal. I learned so much. It was just so well done. And it got me thinking about just policy, you know. So I know that we in the integrative community often talk about, you know, important policy changes that then hopefully affect downstream the actual delivery of care. And one in particular I just wanted to mention was, you know, the non-invasive treatment for acute, subacute, and chronic low back pain, a clinical practice guideline from the American College of Physicians. So, you know, when this came out back in 2017, I think there was, you know, a lot of excitement within our community about how this policy would then ultimately help to transform systems. And I'm just curious, from the work that you have done, you know, how much do policies like that, and I can post it in the chat, the one that I'm specifically referring to, but you know, how much of those are helpful and really needed tools, and how much do policies like that really require then internal people who then take it and really get it implemented within their systems?
I can go for it. And then Heidi, I'd love to hear your thoughts too. I think it's a both and approach. I think guidelines like this give a lot of, I think they show the evidence that these multidisciplinary tools are working. And I think sometimes legislators just go to the doctor or the MD and take their word as truth, which often it is, but we need multiple perspectives. So I think guidelines like this that add legitimacy when sometimes legislators especially don't understand the full scope of the evidence can be really helpful. And I think you need activists on every level. So patients, providers, both primary care providers, specialists, multiple disciplinaries, all using this evidence and talking about it and creating solutions from it.
Thank you.
I agree with Amanda. And also we've been victim to the fee-for-service model in the United States, and a lot of stakeholders have continued to benefit from that. So if people are making money off it, they continue to perpetuate it. A lot of policies are decided by specialists. Specialty organizations, unfortunately, have a high priority on the bottom line for the income of their specialty group. And so what we've found is that much pain care has been like in sequence instead of in parallel. So it's like, okay, go to the primary care doctor, and if their muscle relaxant doesn't help you, then go find a chiropractor, do that for a period of time. And if that doesn't help you, then go to the pain specialist and get a couple of $3,000 epidural steroid injections. And if that doesn't help, and meanwhile, someone is benefiting from each of those. So we found a long lag time between like the evidence shows that multidisciplinary care is more effective and cost effective. Actually translating that into policy is taking a long time, but we're fighting for it.
Thank you so much. Really appreciate it.
So we're hitting the end of our hour, but there is a question in the Q&A that I'll present to you. This is from Aziz Friedrich, and he says, thank you for the talk. What did you find as effective ways to educate MDs and to intentionally integrate varying disciplines?
A couple of thoughts, and I'll have Amanda add to it. So the way to integrate varying disciplines is to pay for it. So the Regional Health Commission got federal funding through a grant to pilot, like actually paying on a per member per month basis. So if you start giving someone a free physical therapist or a free chiropractor per month to take care of that population, then the community health centers are like, okay, we better hurry up and figure out a workflow to figure this out. So that's key, and doing it in a value-based payment model, not in the fee for service. Because again, I'm seeing them for the diabetes, but really their sugar's high because their back pain is high. So if I do that warm handoff to our social worker, but then the patient gets a copay for the social worker or has to go back to the front desk to register so that the social worker has their fee for service, then we have patient drop off. It's not integrated. So we need this value-based payment model. The infrastructure has to support that. The other thing is that we found that in our special population of MDs, to educate them, we do peer-to-peer education. So Amanda has led and helped me every step in the way, but when we walk into a room full of doctors, they are willing to listen to another doctor who is also seeing patients, where I can commiserate with them, and that they're more receptive to peer education. That has helped, and also commiserating with what is hard about their job. And it's really fun to tap into that. When we're training them, we'll ask them, like, what drives you crazy about your patients with chronic pain? And most of the answers, like, if we, and we'll sometimes anonymously survey them, and we get some very brutal, honest, raw answers. But the response to that is like, oh my gosh, don't try to do this yourself. You didn't even have the skill training to totally manage chronic back pain anyway. Use your team, reach out to multidisciplinary experts, ask for help first, let your patients see the physical therapist before they see you. So much of our program has been in response to, like, well, what do you not like about treating chronic pain in your patients? What are you struggling with?
Yeah, and I was going to say very similarly, I think starting with the pain points was really helpful. We knew our providers felt like they didn't have enough time or training. So adding resources that helped alleviate those pain points rather than adding another to-do list for them. And then also, I think having provider champions has been really helpful. So identifying folks within each practice or health center or department that are really on board with integrative practices and trauma-informed care, and helping them also facilitate some of the learning and teaching.
And I just wanted to make a quick, I know we're over time, but Bonnie had answered and had asked a question in the chat, like, are we coordinating with our MAT program? Absolutely. So chronic pain, behavioral health issues, substance use disorder, all of those are amenable to our physical function services with our behavioral health integration, and we understand deeply that it's intertwined.
Thank you so much for your great answers, as informative as the presentation itself. I think we're going to have to call it there. We're a little bit past the hour, but okay, well worth that. Thank you so much again, I want to say. To everybody that's listening in, I also want to say that our 11 previous webinars are available on the Integrative collaborative health website, which I'm putting into the chat right now. You can find those there, and this one will be posted on the YouTube site as well shortly too, so anybody can access this great information. So on behalf of AIM and the collaborative, really big thank you, Heidi and Amanda, for an amazing presentation. I think there may be some closing remarks.
Yes, thank you so much. I mean, what a great, I just feel like this is one of the best talks we've had. I really appreciate both of you and the work you're doing. And you're just so deeply informed on all of the nuances of this, and appreciate all you're doing for your community too. Really love the trauma-informed piece. And I look forward to hearing more from both of you and the continued work there. So I'll just take a few minutes to close us out for this week. For those of you, every year we have a big event that we just finished this year. And so we want you to get on your calendars now our save the date for the 2022 in-person conference that will be in San Diego on October 28th to 30th this coming year. So please put it on your calendars, and we'll look forward to seeing you there in person next year. And finally, just in really speaking to one of the main reasons that the academic collaborative that has really been doing so much incredible work for so many years, decades, really, and the Academy of Integrative Health and Medicine came together was to really build a global community and help lead us through collaboration more and more, because that's really what is needed. And this presentation truly shows that critical need to collaborate even within systems with all the different providers. So imagine the change we could make as a unified global community. And we're really moving towards that. And we invite all of you, whether you're from a system and have a small program, whether you're a university or a nonprofit organization working in integrative health, to join as an organizational member, join the Academy, and help us really grow this movement. So lots of ways to connect with us, all under the AIHM Global tag, whether that's on YouTube, Twitter, Facebook, LinkedIn, and Instagram, for all of you younger folks out there that are moving us forward. And please, come to our weekly wellness webinars, and to the integrative practice series. We hold them most Fridays. We won't have one next week because of the upcoming holidays, but we look forward to seeing you all soon. And I just want to take another moment to thank Heidi Miller and Amanda Harris, and our host, Mitchell Zeifman, and all the great work that you're doing in your institution. Thanks again, and have a great weekend.